Hello everyone, welcome to the USMLE case presentation series on the cardiovascular system. Today we'll be looking at a case presentation on conduction blocks. I'm Dr. Mohabir. I'm a PGY2 internal medicine resident in Miami, Florida. I've taken the step 1 to 3 already, and you could use this video to help you in your preparation for the USMLE exams. All right, let's look at our first clinical vignette. A 68-year-old male patient is brought to the emergency department after a syncopal episode while gardening. He reports feeling lightheaded immediately before losing consciousness. His past medical history is significant for hypertension, hyperlipidemia, and an anterior wall myocardial infarction 5 years ago. On physical examination, he is alert but pale. His blood pressure is 105/65 and his pulse is 48 beats per minute and is also irregular. The lungs are clear to auscultation. An EKG is performed and the rhythm strip reveals a sinus rhythm at a rate of 75 beats per minute. There's a constant PR interval for all conducted beats. However, there is occasional P waves that are not followed by a QRS complex. The QRS complex that are present are widened to 0.14 seconds. So let's look at our possible answers. So the question is, which of the following describes the most likely anatomical location of the conduction block in this patient? Option A, sinoatrial node, B, AV node, the bundle of His, the accessory pathway, or the bundle of Kent, or the Purkinje fibers. So at this point, you could pause the video if you wish and lock in your answer. All right, the correct answer is C, the bundle of His. So if you chose that, congratulations. All right, so let's have a discussion around this question. In order to come up with this answer, you would have needed to know the type of conduction block that a patient has. So on the next slide, you'll see that our patient had the second degree AV block or the Mobis type 2 AV block. And as you could see here on this slide, this is an EKG showing the Mobis type 2 AV block. The ventricular rhythm is irregular, so this is an irregular rhythm. You can see there's um, differences between the RR interval between every QRS complex here, so that makes it irregular. The rate is 60, typically bradycardic. P waves are normal, but some are not followed by QRS complexes. For example, this is a P wave here, and you can see that there is no QRS complex. The PR interval is constant for P wave followed by a QRS. So you can see the PR interval, every PR interval is constant, PR interval constants. So all of these findings are characteristic of a Mobitz type 2. And this slide was taken from the first aid book just to review the different types of conduction blocks that you would need to know about. So let's look at the first degree AV block. You can see it with first degree AV block, the characteristic is mainly prolonged PR interval of greater than 200 milliseconds, as you could see here on the EKG. In the second degree AV block, there's Mobis type 1, also known as Wenke back, where you would have progressive lengthening of the PR interval until a beat is dropped. As you can see in this picture here, you can see the PR interval progressively getting longer until there's no QRS after a P wave. Then there's the Mobis type 2, where you would have drop beats. They're Main difference between this and Mobis type 1 is that there's no change in the PR interval. The PR intervals are constant. In contrast with Mobis type 1, the PR interval prolongs until there's a drop beat. This may progress to third degree AV block. And then there is the third degree AV block or complete AV block, where there is a dissociation between the P wave and the QRS complex. For me, an important distinguishing factor between the third degree AV block and the Mobis type 2 is whether the rhythm is regular or irregular. In a third degree AV block, the rhythm is typically regular, um, and Mobis type 2, the rhythm is typically irregular. And that's because in third degree AV block, the ventricles and the atria is dissociated. They're doing their own thing. That's why the rhythm usually follows the ventricular beats, making it regular. All right, so things to look for on the EKG to know that it's Mobis type 2 AV block. You would have that constant PR interval. You would have drop beats. You would have P waves on the EKG with no QRS following them. And you would have a white QRS complex. In our vignette, you would have remembered that the QRS was 0.14 seconds. Um, this is usually because the block occurs below the AV node, giving you a white QRS complex. All right, in terms of anatomical location, the Mobis type 2 AV block is caused by a structural defect in the conduction system below the AV node. The block is most commonly located in the bundle of His or the bundle branches. Because the block is structural, often due to fibrosis or MI, like was present in our patient, the conduction is all or nothing. There is no gradual fatigue of the tissue, it simply fails to conduct randomly. Alright, the clinical significance of a Mobis type 2 AV block. This is very risky. It can progress to a third degree heart block. Patients are usually symptomatic. Patients could fall because of syncope, presyncope, because their brains are not receiving adequate blood flow. Treatment, usually a Mobis type 2 would always require a permanent pacemaker because of its progression to a complete AV block. The heart rate needs to be maintained above 60. Alright, and why the other answers are incorrect, if you are wondering. Um, the SA node, why is that wrong? Pathology in the SA node will lead to a sinus arrest. So if we look at an EKG with a sinus arrest, we would not see the entire PQRS complex that would be missing. In our patient, we do see P waves, but they simply fail to conduct to the ventricles. Why AV node is incorrect? Because this is a classic site of a Mobis type 1 AV block. Bundle of Kent is incorrect because that's associated with the Wolff-Parkinson-White syndrome, and the description of the EKG is not Wolff's Parkinson-White. And the Purkinje fibers, so why is that wrong? Because a feature of the Purkinje fibers is usually associated with ventricular arrhythmias or specific vesicular block, and our EKG didn't describe anything like that. So the takeaway from this clinical vignette, a very helpful mnemonic to remember. So for Mobis type 1 or Wenke back, longer drop, then you have a Wenke back. Mobis type 2, if some P's don't get through, then you have a Mobis type 2. So hope you could use that to remember the differences between Mobis type 1 and Mobis type 2. Alright, so this is the end of the video. If you like this video, please give me a like. If you want to see more videos like this, you could subscribe to my channel. Alright, take care.